Hello, I'm Jamie Rylance. I'm a pulmonologist and reader in respiratory medicine and global health at the Liverpool School of Tropical Medicine. I'm based in Malawi, and I am co-hosting this with Rebecca Nantanda, who is a consultant paediatrician and a postdoctoral researcher at Makerere Lung Institute, Uganda. Congratulations to whoever got this past the team. This is titled Optimising Lung Health Beyond TB at the Union Conference. That's great in itself. And we expect a really broad range of presentations. I'm going to leave it just about there, just encourage everyone to pose questions as we go along. And Rebecca and myself will pick up those. If you see a particularly important question, feel free to repeat it so that we know there's a lot of people wanting answers. And I will leave the presenters to talk for themselves. Thank you.
Hi, everybody. My name is Eric McCollum, and I'm a pediatric pulmonologist at Johns Hopkins. I have the following conflicts of interest to report, which are around receipts of grants. Today, I'll be presenting on the clinical predictors of outpatient child pneumonia mortality and the development of a severity of illness score for outpatient care in rural Bangladesh. This is a multi-site study. As many of you probably know, from a global perspective, child pneumonia is the leading infectious cause of death for children below 5 years of age. Roughly 800,000 children below 5 in low-income and middle-income countries died in 2017, which is a rate of about 118 deaths per 100,000 children. In Bangladesh, which is denoted with the red circle in South Asia, is a relatively small but very densely populated country. About 20,000 children below 5 years of age were estimated to die in 2017, which is a rate higher than the global average at 135 deaths per 100,000. The goals of this analysis and study were twofold. One, to determine an objective, clinically identifiable risk factors for pneumonia mortality during outpatient care that are both pragmatic and are measurable. And secondly, to develop a parsimonious model that can predict mortality using these risk factors and could be potentially applied in a clinical context in a low-income and middle-income country. So this analysis was done as a part of a secondary analysis of a larger study. So the parent study was a large-scale population-based case control study evaluating the effectiveness of the pneumococcal conjugate vaccine across this northeastern district in Bangladesh called Sylhet between 2015 to 2017. You can see the district blown up on the left side of your screen. The study was conducted at 3 outpatient clinics based in facilities called Upazila Health Complexes in Bangladesh. These are staffed with study physicians. And the children who were enrolled into the study were 3 to 35 months old with suspected lower respiratory tract infection, which is defined as a cough or difficult breathing and either fast breathing or a sign of respiratory distress, largely consistent with the World Health Organization child pneumonia criteria. In terms of, in addition to those 2 goals that I've mentioned, in terms of exploring these clinical predictors, using logistic regression, and then developing multiple scores, we undertook model selection using the C statistic, which is a statistic that summarizes the area under the receiver operating criteria curve, which is used to provide discriminative ability for model prediction. It can be interpreted as the probability that a randomly selected child who died will have a higher predicted probability of death than a child who was randomly selected who survived. So it's, again, used to provide model discrimination. A score of 1.0 would be perfect discrimination, and discrimination is really how well the model separates children who are diseased, in this case, who died, from those who are healthy, in this case, who survived. So we use the C statistic, and then we also use something called the Bayesian information criterion, which is a criterion for model selection where the lowest BIC score is preferred. It's based on the likelihood function, and it favors the most parsimonious model. So in terms of our results, table one, this is just selected participant characteristics. And you can see here among these characteristics, it shows the distribution of these characteristics. It's a largely a young age group, the majority being below 1 year of age. And overall, a low mortality setting, with 30-day mortality being our primary outcome. You can see only 47 deaths amongst nearly 10,200 encounters among children with suspected lower respiratory tract infection and evaluated at these clinics. And in table two, we can focus on the clinical predictors of mortality. Again, just a selected number of predictors. And in looking at the adjusted odds ratio, which is towards the right-hand side of your screen, you can see here that the characteristics of grunting, hypoxemia as defined as an oxygen saturation below 94%, which is altitude adjusted for this population, general danger signs, and moderate or severe malnutrition were all independently associated with an odds of mortality, an increased odds of mortality. These models were adjusted for clinic age and sex. Noting, just a note here, we did not carry forward the variable of general danger signs as it was collinear with moderate or severe malnutrition. Table 3 shows the model performance for mortality. And really the take home here is model 4 performed the best. It had both the highest C statistic, as I just described in the previous slide, and had the lowest BIC, Bayesian Information Criterion. Taking those two factors together, it was selected as the best performing but most parsimonious model, which included age, moderate or severe malnutrition, and hypoxemia, just those three features. In table 4 is the how we develop the severity of a score from these three characteristics. And essentially what you can see in the footnote is that we derive the score by rounding these beta coefficients from the adjusted model and converting that to a score. So rounding it to the nearest 0.5 and multiplying by 2. This is a method that's been used by other investigators to give these score parameters. So when applying the score to this data set from the perspective of the development perspective, you can see there's three different options for thresholds to use. There's a score of 1 or more, a score of 3 or more, and a score of 6. And so what we take away from this is that a score of 6 is likely to be the most desirable score to use, which would really indicate that a child has met the criteria for moderate or severe malnutrition and hypoxemia. And so what you can see is that this identifies a suitably low proportion of this low risk population as high risk, so 1.4%, keeping in mind that the mortality is 0.5%. And although the sensitivity is low, meaning that this model, when applied, doesn't correctly identify children who die, one can see from both the specificity and negative predictive value scores proportions that the high specificity indicates that the score, when applied, 6 of 6, correctly identifies children at low risk of death in the vast majority of cases. And then the negative predictive value is an indication that there's a high probability that children with a score less than 6 will not die. And so taking all this together, if we were to apply a score threshold of 6 to the study population, it would be effective for potentially de-risking or ruling out children at high risk of death. And so one could envision a scenario where a child who doesn't score a 6 is unlikely to be at high risk of death and is therefore sent home with the appropriate treatment. Whereas if a child achieves a score of 6, then they are additionally assessed for other risk factors or other features that might make them at a higher risk of death, to be hospitalized or to have closer follow-up. So in sum, we've used a very large data set from an outpatient population in rural South Asia to develop a pragmatic score that is predictive of mortality using non-invasive, pragmatic, objective clinical features that could be applicable to outpatient pediatric care in rural Bangladesh. And such a score would be most likely applicable to de-risking children in a low mortality setting. Next steps for this would be to conduct external validation. And I want to thank all of those who participated in this study and our donors and funders. Thank you very much.
Hello, everyone. My name is Sweta Patel, and I am a pulmonary and critical care physician from Duke University in the United States. Thank you for virtually attending my presentation on pneumococcal serotype epidemiology following the introduction of 13-valent pneumococcal conjugate vaccine in Botswana. This project was supported in part through the Merck Investigator Studies program. Infections caused by Streptococcus pneumoniae, or pneumococcus, are responsible for over 300,000 child deaths each year. This map displays the mortality rate and total number of deaths from pneumococcal disease among children under 5 years of age in 2015. We see that the majority of these deaths occurred in low and middle income countries, particularly in Africa and South and Southeast Asia. The introduction of pneumococcal conjugate vaccines into many national immunization programs was followed by a reduction in deaths from invasive pneumococcal disease, or IPD, but data from pneumococcal surveillance programs in high-income settings suggests that these gains can be offset by serotype replacement with non-vaccine serotypes. Unfortunately, many low and middle-income countries do not have invasive pneumococcal disease surveillance programs, which can limit our ability to assess the effect of pneumococcal vaccines in these settings. Fortunately, changes in nasopharyngeal carriage of pneumococcal serotypes often parallel changes in serotypes that cause invasive pneumococcal disease. Thus, carriage studies can provide valuable information on the impact of pneumococcal vaccines in countries lacking adequate IPD surveillance. Our objective was to describe temporal trends in pneumococcal serotype carriage among children in Botswana following the introduction of 13-valent pneumococcal conjugate vaccine, or PCV13. To accomplish our objective, we utilized nasopharyngeal swab samples collected from children under 2 years of age who were enrolled as part of 2 prospective cohort studies in Southeast Botswana between April 2012 and December 2017. Botswana introduced PCV13 into its national immunization program in July 2012. The vaccine is administered to infants at 2, 3, and 4 months of age and was introduced without a catch-up campaign. In 2017, the estimated coverage rate for the full series was 89%. Samples were tested for strep pneumoniae using a quantitative PCR assay targeting the autolysin gene. Pneumococcal serotypes were identified using real-time PCR with primers from the Centers for Disease Control and Prevention that detect 40 common serotypes or serogroups. We classified serotypes into PCV13 serotypes and non-vaccine serotypes. The PCV13 serotypes identified by the primers we used are listed here. We used multinomial logistic regression adjusted for age and HIV exposure status to evaluate for an association between collection year and serotype category. We identified strep pneumoniae in 50% of enrolled children. Sufficient DNA extract was available for serotyping samples from 316 children, and we identified 268 strep pneumoniae strains from a final study population of 221 children. 38 children, or 17% of our sample, were colonized with 2 or more serotypes. The median age was 6 months, and half of the children were female. The majority of children were HIV unexposed and had received at least 1 dose of PCV13, with 35% of children having completed the series prior to collection of the nasopharyngeal specimen. I will draw your attention to the figure on the right-hand side of the slide. The bars seen here represent serotypes of identified pneumococcal isolates by year of enrollment. Vaccine serotypes are shaded red to orange, while non-vaccine serotypes are presented in shades of blue. The number of colonizing isolates serotyped is displayed below the enrollment year. The proportion of PCV13 serotypes declined from 75% of isolates in 2012 to 25% of isolates in 2017. The likelihood of a pneumococcal strain being a PCV13 serotype decreased by 36% per year during the study period. While this is a marked reduction in colonization, the proportion of vaccine serotypes isolated 5 years after PCV13 introduction in our study was significantly higher than what was previously observed in Western Europe. Though similar findings have been reported in other sub-Saharan African settings, including Malawi and South Africa. Looking at our data by individual serotype, we found that the most common serotype isolated during the first 2 years of the study were the vaccine serotypes 6A, 6B, and 19F. By the final 2 years of the study, the most frequently identified serotypes were the non-vaccine serotypes 21 and 23B. The increase in serotype 23B is concerning, as it has become one of the most common serotypes isolated from children with invasive pneumococcal disease following PCV13 introduction in other settings, and is often resistant to common antimicrobials. In conclusion, we found that the introduction of PCV13 in Botswana was followed by a substantial reduction in nasopharyngeal carriage of vaccine serotypes in children. Prior work by our research group found a 50% reduction in pneumonia-associated mortality following the introduction of PCV13, and our findings suggest that this may be due to the reduction in circulating vaccine serotypes. However, the persistence of colonization by vaccine serotypes and the increase in non-vaccine serotypes responsible for invasive pneumococcal disease and antimicrobial resistance in other settings may be blunting the impact of pneumococcal vaccination in Botswana. Further efforts are needed to increase herd immunity and develop expanded valency pneumococcal vaccines. We offer sincere thanks to the children and families who participated in this study and to our study team for all their hard work. We would also like to thank the Pelton Laboratory at Boston University for serotyping these samples. Lastly, we thank the organizations listed on this slide who supported our project. Thank you for your attention. I am now happy to answer any questions you may have.
All right, thank you. All right, the chairperson, co-chair members, my co-presenters, good morning. I am by name Dr. Isiaku Amadu from the National TB Reference Lab Zaria in Nigeria, which is under the auspices of the National TB Program. I'm presenting subject title Microbacteria and Other Acid-Fat Organisms Among Presumptive Pulmonary Tuberculosis Patients in Nigeria, Kaduna State. I have no conflict of interest to report. No conflict of interest to report. These are the background of my presentation. Background, challenges, implementation, methodology, intervention, result, and conclusion. Mycobacterial tuberculosis remains the leading cause of death from a single infectious agent globally. But several other species have been isolated in humans, but the prevalence has not yet been documented. Those organisms, Mycobacterial tuberculosis, include the Mycobacterial tuberculosis, Mycobacterial leprae, and then Mycobacterial ulcerans. There are over 100 species of the non-tuberculous Mycobacteria being reported. And although those those NTMs causes clinical disease, which is similar to the MTBC, which is Mycobacterial tuberculosis complex, but sometimes also the diagnostics and treatment dilemmas of healthcare workers present some care dilemmas due to similar characteristics and clinical symptoms. But hence, there is a need and attention to be given to the understanding of the NTMs, since it has been causing serious impact or serious challenges, especially in the managing of tuberculosis. Like a study in Nigeria has shown that in most of the sputum that has been collected, there are over 39% of non-tuberculosis Mycobacteria. Therefore, these studies investigate the phenotypic characteristics of mycobacterium isolate recovered from clinical symptoms of presumptive TB patient in Kaduna State, Nigeria. Now you can see the map of where the study area is on. The study area was conducted in Kaduna State, Nigeria, where we have which is situated in West Africa. And then you see the study also being carried out in the northwestern states of Nigeria. And these are the three senatorial districts where samples are being collected from. This is the methodology and the intervention made. First of all, we've had the microscopy of all the presumptive patients that came in during the period under the study, and the consent for all those of them that are positive for AB microscopy. Their consent form was taken to agree or to disagree for the study to be carried out on their sample. For those that agree and their samples are positive, we went again also to do culture. We do a microbial culture for the sputum samples using the NAC principles. Then after which, for those that are positive, we now decide to do luminescent staining to be able to show that those ones, they are acid-fast bacilli. Then if they are positive, we have now gone to do the SD byline test, which is an achromatic test to show that whether they are NTM and those ones that are not NTM. For those that show positive for the SD byline, it means they are non-tuberculous mycobacteria. And so those are the samples that we are interested about. Now, at the end of it all, this is the distribution of the mycobacteria based on the Lowenjensen culture medium. Out of the 2,212 samples that we have collected from the presumptive patient, about 300 came out positive from the AB, using the AB sample from the entry point, using the zoonecin. And as we see here, those are the ones that we have exposed to culture. When we culture the samples, 272, which is about 90.7% of those samples came out to be positive culture, where about 18, which is about 6%, turns out to be culture negative, while about 10 out of the 300, which is about 3.3%, turned out to be culture contaminated. Now, on the distribution also of the mycobacterium complex using those ones that are positive for culture, we see that by the time we run the SD byline on them, we now realize that 219, which is roughly about 85% of them, 85.5% of them turns out to be true MTBC, while about 42, that is about 15.4%, turns out to be non-tuberculous mycobacteria. And also, coincidentally, also, interestingly, we have about 4%, which is about 11 from the 272 samples we exposed, turned out to be having both MTBC and NTM. Now, at the end of this study, we now come to realize that it's not all the patients that shows that from the entry point that are luminescent positive that are true mycobacterium tuberculosis, and therefore recommending to the National TB Program to integrate a rapid specific diagnostic test for the identification of MTBC, which may later differentiate MTBC and NTM in the diagnostic algorithm, because we realize that there are a lot of patients that come in, and then a lot of the patients are misdiagnosing them, because when the AB says we are positive, then the doctor now goes on to be treating for MTBC, while in the recent they are not MTBC. They are either non-tuberculous mycobacteria, or we call them atypical mycobacteria, or we call them mycobacteria other than tuberculosis. So this is our recommendation on this phenotypic research, and we also recommend for further research on this that will go into the genotypic aspect of this research. Thank you.
Hi, I'm Daniela. I have no conflicts of interest to disclose, and I'm a PhD student at the University of St. Andrews with the Sloan and Gillespie groups. Today, I'll be presenting about a new treatment monitoring tool for Mycobacterium abscessus pulmonary disease. So Mycobacterium abscessus is a non-tuberculous mycobacteria and is the most common rapid-growing mycobacteria causing NTM pulmonary disease in Scotland. Unfortunately, diseases such as cystic fibrosis and bronchitis have been associated with acquiring Mycobacterium abscessus. Treatment for this disease is highly complex. It requires a multi-drug regimen and is dependent on antibiotic resistance. In particular, macrolide resistance can develop at any time throughout treatment. The antibiotics that are given have toxic side effects, such as hearing loss and kidney damage, and treatment itself is lengthy with variable success. This means that treatment monitoring is very important. However, currently it's difficult to assess how well the treatment regimen is working. That's because current treatment monitoring tools largely rely on culturing. In particular, the treatment monitoring tool we'll mostly be mentioning is the Mycobacterial Growth Indicator tube, which can take weeks to achieve results and is using a time to positivity result as an indicator of bacterial burden. It also requires decontamination, which decreases mycobacterial load. So the aim of my project was to develop a treatment monitoring tool that's rapid, quantitative, and does not require culturing. And to this end, we are using a method called the molecular bacterial load assay. This has already been developed for Mycobacterium tuberculosis and has been used in clinical trials where it has shown a correlation with time to positivity results. The way it works is you start by obtaining your patient sample, you homogenize the sample without decontaminating, and you spike in a known concentration of the extraction control. You follow this by performing an RNA extraction because RNA has been correlated with cell viability, and you perform a quantitative real-time PCR. This PCR has two oligosets. The first oligoset is specific to the 16S ribosomal RNA of your desired organism. So in this case, it's specific to Mycobacterium abscessus. And the second oligoset is specific to the extraction control. These are quantified in two separate channels, and you first analyze the extraction control channel to verify that the process has been successful. If it has been successful, you go on to analyze the channel of your desired organism, in this case abscessus. You ensure that there's no DNA contamination or water contamination, and you use a standard curve to convert the CT value obtained to an estimated CFU per mil. We first began by testing the assay to check the limit of detection and efficiency. In order to do this, we had cultures that were grown of Mycobacterium abscessus and CFU plates that were prepared from those cultures and RNA extracted at the same times. And serial dilutions were prepared from these RNA extractions. This led us to find the limit of detection to be 10 CFU per mil. And the efficiency for the 16S RNA of M. abscessus to be 97% and the extraction control to be 100%. You will see some error bars in the efficiency graphs, and this is due to the variation between biological repeats and technical repeats. However, you will also see that none of them went below 90%. The desired efficiency for a diagnostic tool is between 95 and 105%, and on average, these were always above that value. We also wanted to test the selectivity of the assay to ensure that you're only quantifying your desired organism. And for this, we selected common NTMs causing pulmonary disease and other common pulmonary pathogens. And the assay only came up with two organisms, Mycobacterium abscessus and Mycobacterium chelonae. This was expected because Mycobacterium abscessus and chelonae are part of the same complex, and their 16S ribosomal RNA sequence is almost identical with only 5 base pairs difference. We believe this is a good compromise because it's unlikely that a patient would be co-infected with species from the same complex. Based on our in vitro data, we were happy to proceed to testing in patient samples. And we have very preliminary clinical data to present today. So these patient samples were obtained from the Scottish Mycobacteria Reference Lab, as well as some from a clinical trial. In total, we obtained 45 patient samples, and out of these, 44 had successful extractions. I would also just like to highlight that the only samples that gave positive MBLA results were the ones that had been identified as having Mycobacterium abscessus. If we look at the abscessus patient samples in more detail, we have this table here to which I would like to draw your attention to the highlighted in blue patient samples. Both of these had a long time to positivity results of 21 days and 17 days, and they gave positive MBLA results. This was encouraging to us because a long time to positivity result is indicative of a low bacterial burden. Also, this was positive because the MBLA takes a day to obtain results, unlike these samples which took 17 days and 21 days. In contrast, I now would like you to look at the samples highlighted in yellow, which had short time to positivity results of 3 days and 4 days. These gave a negative MBLA result. This was unexpected, and we asked if the reference lab would be able to send us the clinical isolate cultures. When we tested these cultures, they gave positive MBLA results. This showed to us that the issue was not detection of targets, but the target quantity present within the patient samples. Considering their short time to positivity results, which should be indicative of a high bacterial burden, we thought this was quite surprising. Therefore, we believe the issue is potentially lies with sample processing, potentially homogenization, or even storage, which could have led to degradation, especially if the sputum quality was different. In conclusion, we have shown that this new tool has a limit of detection of 10 CFU per mil, an efficiency average of 97%, is selective to the abscessus Chalone complex, and very preliminary clinical data showed a specificity of 100% and sensitivity of 75%. Next steps would require a much larger clinical validation of the assay, and also an assessment of the assay's potential as a treatment monitoring tool in clinical settings by following patients throughout treatment, obtaining consecutive samples from the same patient. I would like to thank the University of St. Andrews team, in particular both my supervisors, Derek Sloan and Stephen Gillespie, Devish Dashmana, Wilbur Sabiti, and Evelyn Dombai, and also the Scottish Mycobacteria Reference Lab for providing us with samples and guidance, and the Cunningham Trust for funding my PhD, and thank you for listening.
Hello. My name is Sepida Sala. I'm a Wellcome Trust Clinical PhD Fellow doing research on air pollution in Malawi. And today I'm going to present preliminary air quality monitoring results from my PhD study set in a rural village in Malawi, looking at individual differential exposures to fine particulate matter, so PM2.5 in this setting. In terms of background, we know that air pollution affects both respiratory and other systems, and that it's associated with acute infectious as well as chronic pathology. The Union Conference theme this year is Advancing Prevention, and the Global Burden of Disease study tells us that around 4.2 million deaths and over 100 million disability-adjusted life years in 2015 alone were due to outdoor PM2.5 exposure. So this is a lot of potentially preventable morbidity and mortality, often in the poorest groups. Air pollution here is also about gender inequality. So in Malawi, cooking, which is pretty much exclusively done by women, is a really important source of PM2.5 exposure. Other exposures in this setting include traffic from cars, burning farmland, as well as brick making. My study was a mixed methods ethnographic study. So I used participant observation, accompanying people throughout their daily lives, alongside air quality monitoring. So we used personal portable air quality monitors to look at individual PM2.5 and carbon monoxide exposures throughout people's daily lives. This allowed for fine-grained exposure data, both by person and by activity. And we also had, in some cases, paired exposure data for men and women in the same household. This data set amounted to 203 hours of data and over 6,000 data points. So our exposure showed a pattern of a baseline with spikes. So these peaks represented activities such as cooking. Our first key finding was that PM2.5 levels in both men and women were high throughout the day, even at baseline, so in the absence of any specific exposure source. At baseline, there was no identified PM2.5 activity. There was no significant difference between PM2.5 levels in men and in women, and you can see by these medians and the overlapping confidence intervals. Our next main finding was that the main PM2.5 generating activity in this setting, both in terms of frequency of exposure, so 2 to 3 times a day, and in terms of magnitude of exposure, was cooking. And you can see this box plot shows paired exposure levels during cooking episodes for men and women. So women at the top here, and men also in the household. You have to note here that it's a log scale. So looking at the medians and the confidence intervals, you can see that we have highly significant differences in PM2.5 exposure between men and women during cooking episodes, with a P of less than 0.001. So we also looked in more detail at specific determinants of PM2.5 exposure during cooking episodes. And we grouped these into 3 factors. So firstly, in terms of cooking devices, most people used a 3-stone fire, but cook stoves of different types were also used. Secondly, fuels. So a lot of people use firewood, but also charcoal was sometimes used. And thirdly, in terms of location, which determined ventilation levels. And this was taken as an ordinal variable, going from inside the house or in a kitchen, which involved the least amount of ventilation, all the way through to a veranda with no walls or outdoors, which was the highest ventilation levels. And these 3 factors were interrelated, with certain types of cook stoves only being used with certain types of fuels. But by far the most frequent setup was a 3-stone fire using wood, although the place varied. So results of a mixed model regression analysis showed that a combination of firewood cook stoves used in well-ventilated spaces, so either a veranda with no wall or outdoors, were associated with the lowest cooking-related PM2.5 exposures. And using this model, we computed point estimates and confidence intervals for 2 scenarios. So firstly, the one above, with firewood cook stoves in well-ventilated places. And secondly, we compared this with a point estimate for 3-stone fires used in kitchens. And the point estimates for the first, for this firewood cook stove in a well-ventilated area, was 217 micrograms per meter cubed. And for the second was 801. And we can see this is a really significant difference between the 2. So in conclusion, we found that cooking in this setting represents the most important source of PM2.5 in rural Malawi. However, we found that levels are really high throughout the day, and even at baseline, where we typically saw baseline levels of more than 35 micrograms per meter cubed. And we can compare this with WHO guidance, which suggests a 24-hour average should be below 25 micrograms per meter cubed. Secondly, in terms of cooking particularly, we found that cooking-related factors, so specifically device, fuel, and location, interacted to determine peak exposure levels, PM2.5. So in our next steps, we aim to firstly analyse an extended data set, looking at 24-hour periods to add to the data we already have, and also to compare this with carbon monoxide data for these same participants. And second, we aim to move on to phase 2 of our study, which involves introducing an outdoor cook stove initiative in the village. So this incorporates giving firewood cook stoves to each household with guidance for these to be used outdoors or in well-ventilated spaces where possible. And this is a combination, as I say, which we found to be associated with the lowest cooking-related exposure levels. Thank you very much.
A warm welcome to all who are listening right now to my presentation about pulmonary function testing and predictive equations in a healthy adult population in the Mbeya region in the southwest of Tanzania. My name is Rebecca Wenzel, and I am a doctoral student at the Division of Infectious Diseases and Tropical Medicine at LMU Munich. First, a few words on the global problem we as lung health community still have, and why studies like ours are such an important contribution to the solution of this problem. Let's have a look at the background. Despite the high burden of respiratory disease, there is still a severe lack of spirometry reference values for many African countries. The reference equations published by the Global Lung Function Initiative, GLI, are still not appropriate to use in all African settings, as they include only a small number of countries from this region. Only very few studies reported reference equations for healthy people living in African countries, and many of them were conducted in South Africa. This is why our study provides prediction equations for spirometric pulmonary function in a healthy, non-smoking Tanzanian population, and compares them to other widely used standards, such as the GLI, and of course, the only other Tanzanian study. A few words on the study design. It was designed as a cross-sectional study, and it was conducted from April to November 2019 in the Mbeya region in the southern highlands of Tanzania. The study incentive was to support the TB-Sequel project, a project which aspires to scientifically describe the lung function impairment suffered by tuberculosis patients after the infection. It is a prospective 1,600 patient study conducted in 4 African countries. To ensure a representative population sample, we applied different recruitment strategies in our study. Our main focus was on recruiting healthy household or neighborhood members of TB-Sequel patients to ensure comparability. But additionally, we also recruited a small, healthy subgroup of hospital employees. Volunteers who screened positive for TB symptoms or other respiratory symptoms were referred to the nearest hospital and, of course, excluded from our study. So how did we exactly proceed? Healthy participants underwent an extensive socio-demographic interview. Afterwards, we took standardized measurements of height and weight. And in the end, participants underwent a spirometric lung function test using a handheld spirometer, the EZ1 Air from NDD. Quality control was performed afterwards according to international guidelines. And then we analyzed the data using descriptive statistics and logistic regression. Our prediction equations were derived for the following parameters: FEV1, FVC, and the ratio of FEV1 to FVC. So what were our results? In our study, we recruited a total of 400 people. From them, a total of 343 participants had usable spirometry results after quality control. So in total, we included 154 females and 189 males. The mean age of participants with valid spirometry results was 32.7 years. And our mean FVC in liters was 3.52. Why is that important? Our observed mean FVC corresponds to 93% of the GLI mean value. But on the other hand, it corresponds to 112% of the older Tanzanian mean value. Mean FEV1 in liters was 2.95. And this value corresponds to 92% of the GLI. But again, to not 110% of the older Tanzanian mean value. To sum up the meaning of those findings, the GLI equations overestimate the spirometry values for the given sex, age, and height in our studied population. The older Tanzanian equations, however, significantly underestimate the spirometry values. All of our findings underline the ongoing importance for locally derived, up-to-date reference equations. On this slide, you can see our newly generated equations for the Tanzanian population for man versus female and different parameters. And on this slide, you are able to see the distribution of the different set scores. We compared our observed set scores, visible in green, to the old Tanzanian set scores in blue, and to the GLI category for others, here visible in red. What facts should you take home with you? Our study provides up-to-date reference values for pulmonary function in healthy Tanzanian adults. The study foundation is based on GLI and ERS task force recommendations, and our established equations and references will be used in the analysis of the TB-SQL project spirometry data. And last but not least, there is still an urgent need for high-quality, prospectively collected lung function data in many African countries. Our study was funded by the DCIF MD program and the TB-SQL study, which is funded by the German Federal Ministry of Education and Research. The study was ethically approved by the Tanzanian Medical Research Coordinating Committee, by the MBEA Medical Research and Ethics Committee, and the LMU Ethics Committee. I would like to thank all the people involved in our study and who helped to make this study possible. Thank you for your attention, and I would be very happy to answer any of your questions in the following Q&A section.
Hello, my name is Catherine Plum and I'm a junior doctor working in Liverpool, and this is some of the research that I did in medical school. I have no conflicts of interest to disclose. This is the title of my project and these are the authors that were involved. And so why did I do this project? The global burden of disease due to asthma and COPD is substantial and particularly great in low and middle income countries, including many African countries. Spirometry is used to diagnose obstructive airway disease according to the Global Obstructive Lung Disease Guidelines, and the World Health Organization have a model list of essential medicines that are required for the basic management of chronic respiratory diseases. These resources are often inadequate in African countries, and so optimal management is inadequate. So this study aimed to explore the availability of spirometry and essential medicines for chronic respiratory diseases in African countries. So a questionnaire was developed that investigated the availability of spirometry and 15 medicines from the World Health Organization Essential Medicine List 2017, which at the time was the most up-to-date list. I was invited to attend PATS-MECOR and Impala Annual Scientific Meeting 2019 to deliver the questionnaires to eligible participants, which were all healthcare professionals who worked in a healthcare facility in an African country who had knowledge on the topic to complete the survey. These were self-completed and returned back to me. So a total of 37 surveys were returned representing 13 African countries. And the questions asked whether spirometry was always, sometimes, or never available. If it is available, then was it calibrated and was there training on how to use it? We can see from the results here that nearly a quarter of people managing chronic respiratory diseases did not have a spirometer. And of the 3/4 that had one, just only half were calibrated and only 2/3 received training on how to use it. If it was not available, then it was asked to select why it was unavailable. And as we can see, the greatest reason for this was unavailability, was lack of training and lack of consideration on how to use it, of needing it. So these are the findings for the availability of essential medicines. And as we can see, these are the medicines that were asked whether they were available, always available, sometimes, or never available. And the medicine with the greatest availability was prednisolone 5 mg tablet, followed by salbutamol 100 microgram inhaler. And the least available medicines were ipratropium bromide and both doses of combination. The The survey also asked how the medicine was paid for by patients, and for all medicines, the most common method of payment was full out-of-pocket pay. Combination inhalers and ipratropium bromide were reported to be most likely paid out of pocket, and salbutamol injection and prednisolone 25 milligram tablet were most likely to be free. There was variable rates of subsidised and mixed method payments. There was an open answer response for why a medicine was sometimes unavailable, and common reasons across all medicines included cost, not on the National Essential Medicine List, lack of training, supply chain problems, procurement challenges, being out of stock, and limited prescription. There was also an option to select why medicine was never available, and the main reasons were very similar, including cost and not on the National Essential Medicine List. So this study set out to evaluate the availability of spirometry and essential medicines where African healthcare workers attending a conference worked. It directly asked about availability, particularly the consistency of this, as well as the challenges. The results are comparable to the Mahotra et al. 2009 survey of PATSME core members that showed 62% of healthcare professionals use spirometry to diagnose COPD. The trends of medicines are similar to that of the Kabirij et al. Systematic review on availability and affordability of medicines and tests recommended for management of asthma and COPD in sub-Saharan Africa, being that salbutamol was the most widely available and combination inhalers the least widely available. We acknowledge that there may be some limitations to the generalizability of results, but this still highlights from this sample that the resources for managing asthma and COPD are not adequate for optimal care. So some of the main limitations to be aware of are the study population may have resulted in over-reporting. Only 13 African countries were represented, so the sample was quite small. Majority of participants were from Nigeria and Uganda, so results are skewed. Recall, there's an element of recall bias as participants couldn't check their facts from the conference centre. And because the survey was piloted in the study, there are flaws in the design of the questionnaire and the phrasing of questions, but these are things that can be learnt for future surveys. So overall, there are general themes that were identified from this study that different individual countries can address. For example, increasing the accessibility of training programs and for spirometry and improving maintenance of spirometers, and for medicines, working on ways to improve supply chains for medicine stock. And countries can think about re-evaluating their essential medicine lists. And overall, this study raises awareness of the need for more available diagnostic tests and medicines for chronic respiratory diseases, and identifies some of the barriers and encourages funding for further research. Having readily available tests and medicines should overall reduce the burden of non-communicable respiratory diseases in Africa and reduce morbidity and mortality. So thank you for listening to my presentation, and a big thank you to PATSME and Impala for letting me attend their conference.
Hi everyone, welcome. Today I will be giving a high-level overview of policy analysis findings from on chronic lung diseases in Africa. Chronic lung diseases, or CLDs, as I'll be referring to them throughout this presentation, are non-communicable diseases, or NCDs, some of the most well-known ones being asthma and chronic obstructive pulmonary disease, or COPD. Like many other NCDs, some of the main risk factors are tobacco smoke and air pollutants, among others. And just as NCDs around the world are becoming more prevalent, so are CLDs. This trend first became apparent in many high-income countries with aging populations, but recent evidence indicates that low and middle income countries, or LMICs, are bearing a disproportionate burden of CLD death and disability, clocking in around 3/4. Although there's really limited data on Africa's CLD burden and even its NCD burden more broadly, Sub-Saharan Africa is estimated to bear a large and growing burden of CLDs. Perhaps this is linked to the lack of investment in this disease area, which is seen at research policy and programmatic levels. To date, there's no publication which scopes CLD policies in Kenya or Uganda or even East Africa beyond just TB. In order to fill this evidence gap, we conducted a desk review of CLD policies at national level in Kenya and Uganda, as well as at regional level in East Africa. We also conducted interviews with stakeholders in both Kenya and Uganda. These included clinicians, researchers, non-state actors, and government officials. Our main questions were, one, are CLD-specific policy at national or regional level existing? And what entity or component of the health system do CLDs fall under? Next question is, are CLDs referenced either as a disease cluster or as individual diseases in various policies? Next, what is the health system approach to address CLDs? And finally, what is the financial investment for CLDs? The findings will be organized across the 4 themes, which were just outlined. First, shocker, there were no policies specific to CLDs as a disease class in Kenya, Uganda, or regionally. However, there is a 2011 asthma management policy in Kenya, which was the only CLD-specific disease policy identified. Generally, CLDs were mentioned under the umbrella of NCDs, which was true in both the desk review and the interviews. In fact, much of the information we gathered is on NCDs simply because there's so little evidence and information on CLDs. Though still falling under NCDs, Kenya does have a chronic respiratory disease program. And at regional level, there was really little visibility into CLDs, which were again captured under NCDs. And for several entities, this was combined with infectious diseases or nutrition, which were really the focus of those programs. The one exception is the WHO Africa region, which does have a webpage dedicated entirely to chronic respiratory diseases, though there's no corresponding policy. By and large, asthma and COPD were the most commonly referenced CLDs in national policies and interviews, again, mainly arising in relation to NCDs. You can see there a quote from a Ministry of Health official in Uganda who noted that asthma and COPD are some of their priority NCDs. At regional level, there was no mention of CLDs as a disease cluster or as individual diseases, the only exception being, again, the WHO Africa's webpage on chronic respiratory diseases, which names asthma and COPD among other diseases. Unsurprisingly, TB was the lung health disease that was most mentioned at both national and regional levels, though it is not typically considered a chronic lung disease. There was no CLD-specific health management approach mentioned in any of the policies, but again, there was quite a bit of information about NCD management, which focused primarily on prevention, especially by mitigating risk factors. You can see in this quote by a Ministry of Health official that prevention is the preferred approach in Uganda since management for chronic diseases is incredibly expensive. In both policies and interviews, the NCD risk factor that was most frequently mentioned as a target for prevention and which contributes to CLDs was tobacco exposure. In addition to prevention, there was mention of the need for improved health services, with some examples cited in the policies and interviews at the bottom of the slide. Finally, we found very little information on financial investment for CLD policies and programs, and this was only confirmed in a number of interviews, which noted that financial resources are just not provided at the same level of disease burden. This quote indicates how, despite changing epidemiological trends, health systems in East Africa are still oriented towards traditional disease areas of HIV, TB, malaria. And the national health accounts for Kenya and Uganda reaffirmed that much of the public health national and foreign health expenditure are similarly skewed. A perfect example is that HIV alone gets about 3 times that for NCDs, even though NCDs now comprise a much larger burden than HIV does. Ultimately, some of the major takeaways, this study found that CLDs are not prioritized at policy level in Kenya or Uganda or East Africa region. That said, there's certainly growing recognition of the burden of chronic diseases at national level, though the same was not observed at regional level. A major challenge is that CLDs remain clumped under NCDs, which are already a relatively under-prioritized disease area when compared with HIV, TB, malaria, even family planning. So if we don't shift away from the traditional infectious disease areas, chronic diseases like CLDs will risk continued neglect, which will only exacerbate their already high burden. Findings from the study have informed these high-level recommendations. The first is critical. Without a solid understanding of the burden of CLDs as a disease area, and then also as individual diseases with varying prevalence, resource allocation and policy prioritization will continue to lag. That's why when you move to the second recommendation, when there are resources, they must be maximized and driven by evidence, given resource constraints. Given the high cost of management, prevention is key. And that includes interventions that mitigate the biggest CLD risk factors, as well as improving routine health screening to catch cases before they worsen, and generally investing in poverty alleviation, which is inextricably linked to health. And finally, a health system response to CLD will need to be enhanced to manage the cases that do exist and which are only growing in numbers. To do this, capacity strengthening will be needed, as well as ensuring access to essential medicines and health technologies. And with that, I'd like to thank my colleagues at the African Institute for Development Policy, the Liverpool School of Tropical Medicine, and the International Multidisciplinary Program to Address Lung Health and TB in Africa, also known as IMPALA. Without all of these folks, this research would not be made possible. So, thank you.
Questions. Thank you.
Thank you. Sorry, my internet connection is slightly unstable, so I'm going to keep my video off. But so regarding the first question, I think it's a valid point around the sensitivity of the score, and I guess what I would bring forward is that what would be perhaps different about the application of this sort of score in a primary care venue that is in a lower mortality setting is maybe not the sensitivity, but rather the specificity. And in using the score as a means to, as I mentioned, to de-risk in the sense of really identify who's at the lower risk and instead for those who may be falling in the higher end of that score, there would need to be perhaps additional metrics applied to those patients to make a decision about whether those patients would receive closer follow-up or be referred to the hospital. So that's how I would take that question. But it is true that I think in a higher mortality setting, I think this sort of score is unlikely to be useful, and so I think it just needs some more exploration from that perspective. Most of the scores to date that have been developed have been in the inpatient setting, and there's been few scores that I'm aware of that have been attempted among outpatients. And then in terms of the moderate malnutrition or the nutritional assessment metric or characteristic, we used weight for age. We felt like that would be more likely to be measured in a routine setting. Measuring the height or length of children is not something that is done routinely in my experience, and it's in a higher volume outpatient setting that might be a barrier to implementation of such a score. And so weight seemed to be more feasible. We did also explore mid-upper arm circumference, but although I wasn't able to get too in depth on that, the score that was had the highest C statistic and was most parsimonious, according to the BIC BIC statistic, was the score that included the weight for age. Thanks.
Okay, thank you so much. The next question goes to Patel about the pneumococcal vaccine. We clearly saw a trend in increasing proportion of those, the non-vaccine type. Looking at the prevention strategies for pneumonia, what does this mean over the next few years? What do you envisage happening when we take care of the current pneumonia burden with the current PCV, and now we have the emergence of the non-vaccine type? Should we be starting to think about that? And then the next one is a clarification again. What was the vaccine coverage, the PCV coverage at the time when you did the sampling?
Great, thank you for those questions. So to answer the first question, which I believe is how to address the rise of non-vaccine serotypes. So I think first, one, with the disclaimer that I'm not a policy expert, I think one high yield intervention will be interventions to increase herd immunity to existing PCV13 serotypes, knowing that data from other settings in low and middle income countries suggests that these serotypes are still responsible for a significant burden of morbidity and mortality, even in the PCV13 era. So if we can, our study and prior studies in other sub-Saharan African settings demonstrated a high rate of residual colonization. So we had 25% of our samples 5 years after PCV13 introduction were still PCV13 serotypes, compared to less than 6% in Belgium and in England. And so interventions to bring down the level of circulating PCV13 serotypes, I think, is one goal that is feasible with what we have now. And with regard to addressing non-vaccine serotypes, I think that we're going to need more data in these settings, to particularly looking at children and adults with invasive pneumococcal disease. What does the rise in some of these concerning serotypes like 23B, as well as, to a lesser extent in our study, but seen elsewhere, 35B, are these serotypes responsible for a significant proportion of severe cases? And if so, then I think development of expanded valency vaccines will be key. Something that we've seen from studies over the last several years is that, vaccination reduces the level of circulating vaccine serotypes, but it doesn't tend to change the overall proportion of children who are colonized with strep pneumoniae.
Thank you. Over to you, Jamie.
Thanks. I was hoping we might be able to talk to Isiaku Amadou about his presentation, but can't see him online. So I'm going to move to Daniela. Many thanks for your presentation. There's a question from Louis Cuevas saying maintaining a qPCR for bacteria that's rarely found in clinics may only be feasible in reference labs, and these labs would have sequencing. Do you see that this qPCR would be most useful, and if so, where, please?
Thanks. So the idea behind the molecular bacterial load assay is actually to be used more as a treatment monitoring tool. So it's to follow progression of disease over treatment. So although sequencing obviously very useful for diagnosis, it doesn't tell you bacterial burden. So our plan really is that this tool would be used to see whether treatment's going well, or whether it's actually, the bacterial burden is increasing or stabilizing, and therefore a treatment regimen might need to be changed. So I believe that it does have a place in reference labs because of that. But I also believe there's certain clinics that would benefit of an assay like this, particularly cystic fibrosis clinics, where Mycobacterium abscessus infections are a concern. And in the long future, we would hope that we would actually develop a multiplex NTM MBLA. So you would have several NTMs that are concerns for infections that could then be used in a reference laboratory.
Great, thank you. And just a quick one. How does the semi-quantitative results correlate with the clinical outcomes in those groups that you talked about? Have you got any data on that?
So I wasn't able to get any clinical data on the patients. Everything was very anonymized in order, to preserve all sorts of GDPR and all that kind of stuff. But they do follow, with TB in particular, we have seen MBLA and MGIT results compared to see how they follow the trend and how the treatment goes on. And they do seem to help. But as you go into treatment, the time to positivity results don't always give you an indication of the bacterial burden, because with treatment, the bacteria might take much longer to grow, although they should grow much faster considering their bacterial load.
Great. Thanks very much, Daniela. Rebecca.
Yeah, the next question is to Sela about the air pollution in Malawi. Very interesting study there. We have two questions. Number one, the PM 2.5 levels, the baseline levels were generally higher than the WHO threshold. Two questions around that. What could have been the sources of that high pollution? And secondly, the intervention that you propose of cook stoves, is it likely to have any really health benefits, given that even the baselines were actually higher than the WHO thresholds? And then the second concerns, again, about the intervention. If we have the outdoor stoves, we worry about children when they're playing in the yard and getting burns. How are you addressing that? And secondly, generally, when we are cooking, we would like to lock our kitchens so that for the security of the food, the fear of poisoning and so forth. So what is likely to be the acceptability of that outdoor cooking as an intervention in a rural community in Malawi? Thank you. Sela, over to you.
Thank you. So these are two really, really interesting questions. If it's okay, I'll ask the thing about the burns first. So our study, we know that there are specific cook stoves. For example, a cook stove used in Malawi in a study called the CAP study, which did have shown significant reductions in burns in children. These, however, have their own issues. They're very expensive, for example. And our study has really aimed to look comprehensively at air pollution in the context. So burns and air pollution are only two of a range of health risks for children and adults here. And the wider context, Rebecca, that you talk about is things like the reasons that people do tend to cook in a kitchen, for example, for privacy or for security or other reasons. So our study really looked globally at these issues. So in terms of the immediate intervention, as we said, we're looking at wood burning cook stoves, trying to guide people to cook outside where possible. And a part of our evaluation will look at the question that you asked about how how appropriate it is, and the number of people doing this at different times, particularly with the rain, for example, will tell us a lot about the feasibility of this. In terms of the burns, we hope that wood burning cook stoves will have an impact on reducing burns as well, as they make sure the fire is more enclosed rather than having an open fire. But we know that this is not a complete solution, and this comes on to Eric McCullum's question. So we found that in a recent systematic review that there actually is quite limited evidence for lung health benefits of improved cook stoves on their own. But we also know that widespread and sustained uptake here is an issue. So we know that in the village that we spent a lot of time in, cooking was going on about 3 times a day on average, and there were also other sources, although quantitatively they were less important. So we're really looking at the feasibility now of a community level intervention, looking at if everyone or a decent percentage of people in the community do use this cook stove, whether that increases the chance of reduction in these general baseline levels. As we saw, levels were coming down through the night and coming up again in the morning. So that's a possibility. But ultimately, I think the ethnography found that there were wider structural issues behind these air pollution levels that also then contribute to other health issues. So things like malnutrition. So ultimately, as a public health person, I think the real answers here will be structural. So improved energy, clean energy access across the country, particularly in these rural areas, and then better food and water insecurity. And these things will come together to provide structural answers to the questions. Thank you.
Thank you, Seth. Coming on to Rebecca then, thanks for the spirometry. Good to see it being done at really very high levels. It's always difficult to compare between countries to know whether there are significant precursor events which affect the whole population, or whether there's ethnic changes that represent the changes between countries. When you've compared, you've got different results compared to Malawi and some West African settings where they found considerably reduced FVCs. I don't know whether you want to comment on that in Mbeya.
Yeah, so actually we found quite significant differences between all those countries. We even found significant differences between the countries in East Africa, not only between East and West, but also between the countries in East Africa. So it is very important to have those FVC values for every country.
And a follow-on question then, I guess the GLI is a little bit difficult to implement mathematically, and you've chosen to do a linear regression model. Do you think that's going to be the way that country level lung function norms are calculated, or do you think that they need to go into the overall GLI picture to give a broader global scope?
Well, ultimately, I hope it would go into its GLI. So we have all countries in the GLI. That would be the end goal. But till that happens, we have it country-wise.
Okay, that's great. Thank you. Rebecca?
Our next question is to Kathy about the access to diagnostics and medicines for non-communicable lung diseases. In your survey, did you consider looking at spacers for children? For us to be able to actually deliver medicines effectively for children, we would need spacers. I'm interested in knowing whether the spacers were considered and what proportion of these countries actually had spacers.
I didn't investigate spacers. We just used the medicines that were on the World Health Organization essential medicine list, which doesn't include spacers. So I think my study more focused on the availability of the medicine rather than the delivery of it. But that's obviously something that is can be investigated in the future and potentially included to be essential for delivering medicines.
Okay, thank you.
Okay, and with 2 minutes left, Emma, just coming to you, just the different, really interesting, there's comments that there's no CLD policy in Somalia. Where do you draw a line between guidelines and policies, and did you look at those differences? And second thing, given the prevention and treatment paradigm, how do you account for policies on prevention apart from tobacco, and who was responsible for prioritizing these CLD related policies?
Yeah, thanks, Jamie, for the questions. It is a fine line between guidelines and policy. Typically, I mean, if you have guidelines with the WHO, those would be adopted at national level, but we haven't really seen that to date. And as for clinical guidelines, something like asthma, which was the only CLD specific policy identified in East Africa, it does little. It's helpful for management at clinical level, but it does little for resource allocation or broader structural changes that are needed to really address the burden of CLDs, in this case, asthma. For your second question, I mean, it really, the responsibility lies with the ministries of health to prioritize for their country. And a lot of this, to prioritize, you need different health and epidemiological data. to indicate just how big of a burden different diseases or disease clusters are. So unfortunately, a lot of that is lacking, which is why this research is really critical.
Great, really important. We're coming up against our time. I'd just like to thank all of the speakers. Really good job and nice questions. As always, it'd be great to have another half an hour to ask questions. We don't have it. Thank you for your participation and hope to catch up in a similar session next time. Thank you.